We're going to go on directly on with the program. By the way, I did want to introduce Miriam Rafiq, who is our phenomenal coordinator for the Center for Global Public Health. Thank you. And so now what we're going to do is we're going to move on to the faculty panel, which is our panel number 1. And if I could invite Professors Lee Riley and Jason Coburn and Kara Nelson up, we're going to speak here. And I'm going to introduce, I'm going to moderate this. So if you could just come up here. All right, the idea here is to have, as I said, to set up the situation, which Eliya Zulu did so nicely, and then to start in looking at what are solutions, what are possible strategies. And so we just heard one innovative approach. And so what we wanted to do is have a panel of our several faculty at UC Berkeley who are associated with this project and with the Center for Global Public Health, and who are actually already for many years working in slums on essentially addressing slum health in the broadest perspective. And as Eliya Zulu mentioned, it's not just about health. Health doesn't start at the doctor's clinic. It's much, much broader. It's about infrastructure. It's about water, and that's precisely what Jason and Kara, for instance, work on. And so what we're going to look at, this particular panel is going to focus on what we've learned from our research about the phenomenon of slums that indicate it might be different from the realities of general urban and poor rural communities, which we already started hearing about. What have we learned are the determinants of health in slums and relate to the special realities of slums? And what modification of practice and approaches have we observed or tried in the context of slums? So in other words, looking at the actual experiences of these 3 faculty members. And we're going to be hearing from the slums in Nairobi, from Professor Coburn, and in Brazil, Dr. Lee Riley, and potentially some of his work in India. And then Kara Nelson is going to discuss some of her work in Ghana and India. Okay, so I'm going to right now just introduce them all at once, so I don't have to keep coming up when it's each person's turn. We're going to start with Lee, I believe. Okay, so Lee is, Dr. Lee Riley is a professor in, I can do this because we're in the same division, and he's a professor in actually 2 divisions in the School of Public Health, in infectious diseases and vaccinology, and also in epidemiology, and he's been here since 1996. And I'm not going to go through this litany for each professor about how many papers they've published and what prizes they've had. Believe me, they're all there. But essentially, just to focus on what their area of research is, and their international work. And Lee started working in Brazil in 1984, and also in India, and has been doing a lot of work around infectious diseases like tuberculosis, nosocomial infections, leptospirosis, and diarrhea. That in Brazil, and then in India, mostly focused on tuberculosis. But a lot of the work he was doing in these countries happened to be in slums, and so this started getting him thinking about, what is it that's different about these areas than the rest of the urban populations. And actually, when he took a sabbatical a couple years ago, he calls it slumming, and he actually spent a lot of time in Mumbai and a number of other slums, not as slum tourism, but actually just to be there and to understand, to grow to understand exactly what Eliya Zulu mentioned, which is the access to health issues and how it's much bigger than health itself, or what we consider medical health itself, and so he came back with this concept of trying to focus energies on slum health, and also having realized that a lot of the issues some of are infectious, but really a lot are chronic diseases that are actually like hypertension, rheumatic heart disease, things that you could actually do something about early on, but for lack of health access become really huge problems that pose a big financial burden on the entire system, just because of this issue of lack of access. And so he's going to speak about this. Then we're going to hear from Professor Coburn, who is an associate professor in the Department of City and Regional Planning and in the School of Public Health. And he's also a founding member of UC Berkeley's Global Metropolitan Studies. And his work really focuses around connections between urban planning, public participation, and population health in a number of different cities, and has been working, I think the work he'll talk about today is on slum upgrading in Nairobi, Kenya, and he's been working not just himself, but actually bringing large teams of students from UC Berkeley there in really exciting projects. And this is a partnerships with the non-governmental organizations and the University of Nairobi and UC Berkeley. And he's had published several books, and for instance, one of them is titled Towards a Healthy Population, People, Places, and the Politics of Urban Planning. And so that's really taken a turn towards understanding the underpinnings of slums and slum health, but from a more infrastructure and land rights point of view. And then we're going to hear from Karen Nelson, who's an associate professor in civil and environmental engineering. And her research program addresses critical issues that are at the intersection of public health and the environment. And this was focusing on reducing the threat that are posed by waterborne diseases. And essentially addressing this by improving engineering infrastructure to make more effective and affordable and maximizing environmental benefits. And so this, some of the examples have to do with mechanisms of pathogen inactivation, water reuse, low-cost treatments, and technologies for drinking water, sanitation, and wastewater. And so she's actually going to just speak about some of her work. She's working currently in Mexico, Bolivia, Ghana, India, and China, but will focus the work she presents today on Ghana and India. And that's it for me. I'm going to ask Lee to come up. And the idea is to have a 15-minute presentation by each of our professors, and then a discussion where we kind of address some of those questions with questions from you as the audience.
It's a real pleasure to share some of the work that we do. And as Eva mentioned, I've been working on various infectious disease problems overseas. And in the process of doing these projects, I discovered that many of the people that we saw in doing this research project happened to be residents of slums. And so I didn't really start out working in slums. It's just that I made a discovery over many years of working abroad that the population, a large proportion of the population that we were working with happened to just come from slums. And one of the struggles, I'm a physician, and I don't want to just do research as a physician. I still have this drive to be able to do something about the problems that we see. And so one of the struggles that I've always had is as an academician, doing basic biology, epidemiology research, are there something that we can do? Do we, as researchers, do we have a role? And as Dr. Zulu mentioned, it's not enough to just point out the problems. We need to be able to do something. And I think as researchers, we can do something, and that's what I want to try to share with you today. And I want to emphasize in my presentation this issue of the neglected population. And I'll see that there are many levels of neglect that I think you can see as I talk. So this is these are billboards. If you go, this is in Chennai, formerly Madras. And if you cross this bridge at night, okay, into the city, this is what you see. And you think India is represented by what you see here. Okay, but if you go cross the same bridge in the middle of the day, this is what you see. Okay, and this is what you see. When things like earthquakes happen or natural disasters happen, these people get immediate attention. Haiti had 15 days of fame immediately after the earthquake. But these conditions existed in Haiti long before the earthquake happened. And we don't recognize this population in the slums as refugees. When they're given a refugee status, there's immediate attention placed on them. But these refugee populations have existed for decades. And they're just continuing to explode, as Dr. Zulu mentioned. And this is a report that came out that was produced by the United Nations Human Settlements Program. How many of you have ever seen this report? Okay, when I asked the School of Public Health people 2 years ago, none has seen this report. And it's really amazing. This is probably one of the most important documents ever produced by the UN. And this is something that you should all read, because this is really the most comprehensive report on what's really going on in the slums. And so, as Dr. Zulu mentioned, there are certain definitions that the report used to define for slums. And what I'm going to try to talk to you about today is how these definitions influence different types of diseases that we see in the slums. And so, right now, worldwide, more than 1 billion people live in those conditions, those settlements that meet the definition of the slums. 2 billion in 30 years. 40% of the combined urban population in all developing countries right now. 78% of combined urban populations in least developing countries. So in least developing countries, this is the norm of their life already, okay, so almost 80%. And so in this report, they looked at demographic, spatial, economic, legal, and social indicators, 1 billion people in the world who live in the slums, life expectancy, under 5 mortality, access to improved water sources and sanitation, slum upgrading programs, poverty reduction programs. But what's missing are the health burden measures. And the reason this is so is because it's not easy to do this. You have to do something like Dr. Zulu to really get the kind of information. You have to go into the slums to get the information, the type of data that Dr. Zulu was able to present. So where do we get data about urban health? National Mortality Registry, hospital discharge diagnosis, health insurance database, demographic and health surveys, multiple indicator cluster surveys. Okay, these are types of surveys that the formal health sector or formal these are formal ways of getting information. But in many of these slums, births may not get necessarily recorded. Deaths may not get recorded, right? So how do we get this kind of information? There's a real information disparity here. And you know about, in schools of public health, we study DALYs and YLDs and et cetera, right? And how do they get the information? Okay, so there are 3 reports. The first one came out in 1990, looked at 107 diseases and injuries in 8 regions of the world. They looked at 10 risk factors that account for these 107 diseases. Another report came out in 2001. They looked at, well, this is based on the 2001 survey, but the report came out in 2005. They looked at more diseases, 14 regions, 26 risk factors. The most recent one, there's actually a draft of this that's come out. But this report looked at data from 1990 to 2005, disease burden, 21 regions in the world, more than 20 diseases, 43 risk factors, okay? And these are the risk factors that the most recent report have examined. But within those risk factors, only 2 that are in the definition of slums are included, and that is unsafe water, inadequate sanitation, and hygiene. Missing, even in the most recent report, are the 3 other components of the definition: poor structure, quality of housing, overcrowding, insecure residential status. So if you look at these, what kind of diseases will be missed, okay? So poor structural quality of housing, land and mudslides, earthquakes, unintentional injuries and deaths, okay? Flooding, leptospirosis, cholera, diarrhea disease, hepatitis, dengue. Fire, burn injuries, death. Vertical multi-story housing, falling injuries. Residents next to dumps, burn injuries, toxic exposure, toxoplasmosis, hydrocephalus. I don't know if you've ever been to the Philippines, but these communities that live right next to these city dumps, these kids eat the garbage from these dumps, and they develop, the pregnant mothers develop toxoplasmosis, and then the child are born with congenital toxoplasmosis, hydrocephalus, et cetera. These are the kind of things that would not even be considered by this most measures of global burden of disease. Lack of residential infrastructure, street lighting, violence to women, intentional injuries. This thing here, I don't know if you know, but in the last 10 years, there's been a lot of earthquakes. More than 1 million people died of these earthquakes around the world. More than 90% of those people who died were those who lived in slums. Okay? Several years ago, there was an earthquake that happened in Bam, Iran. About 32,000 people died. The earthquake of the same magnitude happened in California a few weeks later. Only 2 people died. And the difference was structural quality of housing. So these are sort of typical vertical structures. People, this is the slums or favelas in Brazil. You have these flat roofs, and people spend most of their time either getting drunk on the top with adults, and the kids fly kite up there, and they fall, and they have falling injuries. Okay? These are all dependent on these kind of structures of these housing. Overcrowding, these are all the kinds of diseases that you get from overcrowding, which is not even included among the risk factors in the global burden disease. Insecure residential status, you have informal tenure and lack of title deed. What happens when you don't have title or deed? Lack of representation. You have exclusion from healthcare services, decisions important for the community that affect health, and for instance, placement of toxic waste dumps. next to these communities. These people have no say in the matter where these dump sites get placed. This happens in the US as well. Eviction, poor access to healthcare services, schooling, work, traffic accidents. In Shanghai, I don't know if you've been to Shanghai recently, it's the most amazing city, but to make that city, they had to displace more than 2 million people out into the periphery, okay? But these people still have to go back to where they were working in the center of the city. In the process, they get into all kinds of traffic accidents and all kinds of injuries that they would not have experienced. Toxic chemical exposure, low service utilization, you have chronic diseases, unwanted pregnancy, STIs, etc. So if you have, in these slum conditions, you have these diseases that you can't really see. They're sort of invisible diseases that will only become manifest when they develop complications of these illnesses, okay? So if you sort of divide unseen diseases and diseases seen by the formal health sector, hypertension, you can't see hypertension. Okay, some of you in this room has hypertension now. Can you see that? So when do you see hypertension? When people have stroke or congestive heart failure. That's when they're seen by the formal health sector. Diabetes, you can't see diabetes, but you can see end-stage renal disease, blindness, chronic infections, recurrent pharyngitis, just sore throat. Okay, you can see, you may be able to see that, but you don't see rheumatic heart disease, the complication of that disease. Skin infections, glomerulonephritis, kidney disease. Tuberculosis, people are just coughing away. That's not necessarily TB. You don't really see TB or complication until somebody develops multi-drug resistant TB. HIV infection, you can't see HIV infection until somebody develops AIDS or opportunistic infections. Unintentional or intentional injuries, you have chronic osteomyelitis, because people, if they are intentional injuries, unintentional injuries, gunshot wounds, knife wounds, they don't necessarily go and seek medical assistance. They just sort of wait, and then if they do that, they develop these chronic conditions. So I just want to tell you quickly about what we do in Brazil. We work in several cities, but most of our projects in Salvador, Brazil. So we have a project in leptospirosis, tuberculosis, and rheumatic heart disease. So this is the city of Salvador. It's the third largest city in Brazil, about 2.5 million people. And 60% of the city is considered to comprise of slum residents, okay, according to that UN definition. And most of them look like this. So leptospira looks like this. It's a bacteria. It's a spirochete. And when people, so just go back here. So during the rainy season, this thing gets just completely flooded. People have to walk through these. And these spirochetes are excreted from rat urine. So the urine contaminates the water. People have to walk through this. They bore through the skin, enter the bloodstream, disseminate all over the body, go to the liver and spleen, and you get kidney failure and you die. Okay? And this happens also. So this is a man with hepatitis, and he has a yellowing of the sclera, which indicates that he has liver disease. And this is, he's undergoing peritoneal dialysis because his kidneys have shut down. Okay? When they develop kidney shutdown, more than 25% of them will die, no matter what you do for them. This is an easily treatable disease. Very cheap antibiotics can be given early in the course of illness, but if you don't catch them early, they die. This is the most severest manifestation of the disease, where they get pulmonary hemorrhage. 80% mortality if you have that. This work is being done by, is being led by Albert Koh, who is a Cornell professor. He's been in Brazil for the last 15 years, and this is his team that works on these favelas. On Sundays, they go door to door doing surveys, because on Sundays people are home. Why leptospirosis? It's a paradigm for infectious diseases of urbanization, especially of slums. If you don't have this rat density, the large rat population, you don't have this disease. Okay? This is also an example of a disease that's affected by both natural and man-made changes in the environment. And what's interesting is that intervention against this disease may have an impact on many other diseases that's related to water. Let me just go through this quickly. The other, as I mentioned, we know what's associated with this disease. All we have to do is close up the sewage and provide safe water. And so it's a change in the infrastructure that needs to be implemented. And when we first reported our findings, and we were able to report this in Lancet, the Brazilian government was actually quite embarrassed that this problem of poverty exists in their large cities. But But instead of kicking us out, they actually contacted us and they asked us to set up a similar surveillance system in other parts of Brazil, other cities in Brazil. So this was an example where research actually led to some intervention on the part of the government. Okay, so research does work. Okay, all we had to do was provide data, but it has to be really specific data. You can't just have general sort of data. You have to be able to provide kind of data with which the people in position of power can use to make interventions. Okay. Let me talk about rheumatic heart disease. This is a more recent project. Rheumatic heart disease is a disease that's an autoimmune disease. It's triggered by group A streptococcus. It's a very common bacteria that's in our throat and our pharynx. If you get repeated episodes of sore throat with certain strains of this organism, then people will go on to develop valvular disease, cardiac valvular disease. Okay, your immune system starts damaging the valves in the heart. So actually what's interesting is that this disease used to be very common even in the US in the 40s, before the antibiotics became available. And so a lot of what we know about rheumatic heart disease came from studies in the temperate zone countries. And it turns out these studies that were done in these countries may not really apply to what's going on in developing countries right now, especially in the slums. Rheumatic heart disease are most commonly seen in residents of slums all around the world. Okay, and so WHO did a prevalence study, and the peak prevalence of RHD is 24 to 35 years. But in Brazil, there are two studies that were done by collaborators. The mean age in one study was 12 years. In another study, it was 9 years. So this disease is being seen in little kids now instead of young adults in Brazil. Okay, this is a totally changing epidemiology, and this is because of what happens in the slums. Disease prevalence measurement, so these are what we're doing. We're trying to really estimate disease burden. We also want to try to develop a simpler diagnostic test, and then trying to understand risk factors for rheumatic heart disease. Is this a problem of access to healthcare service, differences in circulating strains of group A strep, differences in diversity of group A strep strains, or differences in other biological characteristics? And this work was done by our PhD student in EPI, Sarah Tartov, and she did several studies. One was a review of surgery for valvular diseases. And this was possible to do in Salvador because there are not many cardiac surgeons. So she was able to contact all these surgeons and then try to review their logs for cardiac surgery. And then she did chart reviews of all these patients. And it turns out the valvular surgery, more than 50% of cardiac valve surgery done in Salvador, Brazil, is due to rheumatic heart disease. Okay? This is a huge, huge problem. She also did a study of looking at kids with sore throat in 3 different clinics. 2 of them predominantly took care of kids from the favelas, and the other took care of non-favela kids. And this was a big study. She obtained the group A strep, genotyped them, characterized them, and she found, this was done in 2008. Let me just go through this. So the point that I want to make is, in one hospital, this is the non-favela hospital, the diversity index of this group A strep was 0.92. In the favela clinic, 0.97. In the another favela clinic, it was 96. And these were, so if you look at this, the ones from the non-favela kids, the diversity index of the group A strep was actually closer to this Lancet report. It was a meta-analysis that was done, reported from high-income countries. Okay? Whereas the ones from the favelas were closer to those reported from low-income countries. Okay? So in the same city, the diversity index of the kids from the slums were actually closer to those found in the low-income countries, and then the ones from the non-favela kids were closer to actually to the high-income countries. And there's actually a vaccine that will probably be coming out for preventing group A strep. If this vaccine were to be applied in the same city, it will have less of an effect on the favela kids than in the non-favela kids, okay? So it has nothing to do with poverty or any of these things that we always talk about. It's biology. But this biology is influenced by the conditions in the slums. So this is Dharavi, looking at TV. Let me just go through this quickly to make it short. So this is Mumbai, the largest slum in Asia. And this is a 10-year-old boy who has disseminated tuberculosis. Okay? And he got this disease probably from his grandmother. His grandmother, several months before this, was diagnosed with pneumonia. Okay? So she was given broad-spectrum antibiotics. Of course, she didn't respond to these antibiotics because she had TB. She went to another clinic. She was given steroids. Of course, giving steroids to someone with TB is like throwing gasoline into fire. She quickly died after that. Okay? But in those period of time when she was not diagnosed, she was giving infections to all her close contacts, including this little boy. Okay? That grandmother went to this local clinic here. It's a private clinic, and this is where she got those antibiotics. Okay? So yes, we can bring private sector to that. Actually, in the Mumbai here in the Dharavi, there's actually a government clinic right next to this huge community, but they don't use people don't use that service. They go to these private clinics because if they pay for these drugs, that maybe they're getting better quality. It turns out they're not getting better quality. Okay, so it's not enough to just provide private services in this way. They have to provide quality care services. Okay. But with TB, that's not easy because you need a diagnostic test. Okay, how do you give diagnostic tests to people who live in places like this? They're not going to go to the clinics. Do you go to a clinic? Do you go to see a doctor if you have a cough? They're not going to get to a doctor until they start vomiting or spitting out blood. Okay, that's when they get it. But it takes several months before somebody will get to that stage. And during that period, they're giving infections to all these other people. So this is not a problem with an individual patient. It's a problem with this whole community. Okay? So if we were to come up with a diagnostic test, we need to be able to take that test and go into these communities and not wait for these people to come to a clinic. So this whole concept, the point of care diagnostic test that everybody wants to do, will not apply for TB in the slums. So we need to be able to get to these places. And so where do we go from here? So we can't wait for alleviation of poverty and disparity and inequality. We've been talking about this for many, many hundreds of years, right? We already know this, okay? We cannot wait for social capital development, technology transfer, UN Millennium Goals, okay? It's not, these people, this is just not enough. We need to act now to formally recognize the existence of this population. That's number one, okay? As I mentioned, for 20 years, people have been doing global burden disease measurements. And yet, to this day, they are well-meaning, they still do not include the definition of slums to incorporate into their risk factor analysis. So even researchers have not yet recognized the existence of this population. We need to assess the burden of disease in this population, develop new metrics, conduct research and report findings in international journals, okay? But they have to be really good quality research. Provide data for national governments and identify and implement novel interventions specifically designed for slums. So I'll stop here. So a lot of people have worked on this from Berkeley, as well as Brazil, and then all of our collaborating organizations, and then all the people who actually work in the slums of the world, and the people who live in those places. Okay, so I'll stop here.
Okay, I'll try to be quick and try to talk about specific interventions, building on what other folks have said already. And I just wanted to preface this with two comments. One is that this conversation that we're having today and going to continue has really led to a collaboration between Lee, Riley, and myself and others, including some NGOs in Africa, including African Population and Health Research Center that we're partnering with. So these conversations across disciplines, across sectors really do matter to think more broadly about these interventions. And I think it might be one of the first or one of the very few collaborations between infectious disease and School of Public Health and Department of City and Regional Planning here at Berkeley. I also want to acknowledge that what I'm going to talk about is really not my own work, but is a result of a collaboration with an organization called Pamoja Trust, which is an NGO in Nairobi. They will also work throughout Kenya and other parts of sub-Saharan Africa, really empowering the urban poor and doing slum upgrading, and the University of Nairobi and UC Berkeley. So this really comes out of a collaboration, and if there's one major point to take away from what I'm going to talk about, is that improving lives of slum dwellers and the conditions in slums, it's about collaboration and partnerships that public health, planning, engineering, one public or private agency can't do this alone. I also want to remind people that today is World Health Day. Everybody knew that, right? That's why we're here. We planned this event just to happen to be. And so if you go to WHO's website today, you'll see all the hoopla about it. But what's their big recommendation? Hard to read on this slide, but it says promote urban planning for healthy populations, healthy development, urban living conditions, participatory governance, and all the rest of the things that I'm going to talk about. So I'm happy to report that WHO is thinking about what I'm going to talk about and backing it, but it's very hard to find the word informal settlement or slum, even in today's WHO report. 2 weeks ago, there was the World Urban Forum in Rio, really talking about the conditions of cities around the world. UN Habitat sponsored that, although WHO and a number of other health organizations were there. Increasingly, collaboration between WHO and Habitat and others. The image on the top right is the latest State of the World Cities report, 2010-2011, comes out every 2 years. And the major finding from that is that, or one of the major findings you may have seen in the international press, I don't think it showed up in any US publications, is that urban planning and slum upgrading can work and does work. Over 10 million people in Brazil, because of both a national and local commitment in Brazil, have moved out of and avoided slum living conditions, and 227 million people worldwide in under a decade. That's under a decade. So a commitment from government, from international agencies, and with local NGOs really at the table and driving this can work. I'm going to talk a little bit about Nairobi in a slum not too far away from Dr. Zulu talked about, called Mathare, which is about a little bit smaller than Kibera, but still significant size. But in Kenya, as we talked about, slums are the majority of the urban population, but a very small percentage of the land area. They're growing, and there's very little focus from the city government, from the Nairobi City Council or other city governments, and this is true around the world, that cities, mayors don't have much power and traditionally haven't had much power. Central government decisions have not focused on urban conditions historically. That is changing, and there are some exceptions, with Brazil being one of the major exceptions. And why urban planning? Because place matters. We've talked about this already today. I'm not going to get too much into that. The one image there on the bottom right is from a Amnesty International report that came out right as our team was about to go to Kenya last year, where they went to Mathare and really looked at and made a sort of really bold statement about the human rights violations in Kenyan slums, particularly around a project of urban water cleanup, which I'm going to talk about in a moment, which is part of our project. So really, part of this work of research, of partnerships, is raising the profile of urban living conditions and urban health. This is a little model that we've been working with, again, put together with our partners about our integrated approach to improving the lives of slum dwellers and informal settlements. And it's really trying to break down and break apart traditional public health approaches that focus on one disease or one health behavior, or even traditional planning or engineering interventions that focus on one piece of infrastructure or one aspect of economic development or livelihoods. And it really tries to integrate, we went a little crazy with the P's here, but really thinking about the physical, place-based characteristics as we've talked about, partnerships being really important. NGOs can't do this alone. International donors can't do it alone. We need government, both national and local government, and international donors, all to really begin to get this message, and that's what we're trying to do today, including service providers. Building power at the local level for accountability and informing decision makers is also a key part of this. If you come in and intervene and don't leave a legacy of leadership and power in place, it's not enough. And also really changing policy. To change programs and interventions is one thing, but to really change policies is our long-term goal. Bottom right here is Nairobi's new metro plan, which Nairobi's trying to do a lot of interesting planning, including vitalizing regional planning, not just very local planning. So this is a metro, Nairobi metro region. You can look through this report. It's pretty glossy and pretty interesting, but there's very little attention to the conditions of slums, largely focused on transport, which is a major issue in Nairobi. So how do we implement in our practice this integrated approach? Very hard, but let me give you some examples of what we're trying to do. Again, we're working in this slum called Mathare with our partners. Pamoja Trust is really the NGO that's really shaping and driving much of this work, and we're providing some of the support. And it really starts with Pamoja and their sister organization called Muungano, which really builds microcredit saving schemes at the informal settlement level. In fact, there can be multiple, and often are small little saving schemes, often organized by women, which build economic power, but as importantly, political power. They organize community around broad issues. And they often engage other organizations in the community, whether they're faith-based or other NGOs that may be working in there. They also provide a place to bring people together to begin to make the unseen visible, as Lee and others have mentioned. Counting these populations, as African Population and Health Research Center has done for many years in Kenya and across sub-Saharan Africa, is critical to both document who lives there and the various issues and the spatial variation, even that you find within one slum. Even in a place like Mathare, not all of the smaller informal settlements that make up this large slum have similar issues. And that's why mapping for us is very important, to count but also spatially map what's going on, and then to use these data to inform planning and policy making. And that's what I'm going to talk a little bit about. And that planning includes this integrated strategy to really focus on negotiations around land tenure and housing and land rights, improving housing conditions, working with architects and planners like myself, we do that, and focusing on how does infrastructure and issues of economic livelihoods relate to all of these issues, not segmenting these apart. Very difficult to do and not always successful and takes time. I mentioned the issue of this is the aerial image of the Nairobi River and a few of the informal settlements in Mathare that we're working in. Last year, the UNEP, United Nations Environment Program, and the Ministry of Environment launched a major plan, had been in the planning stages for a number of years to clean up the Nairobi River and its tributaries. And a major piece of that, the first piece of that, was to clear 30 meters on each side of the river and its tributaries. This is an article from the Daily Nation in Kenya on estimates of over 127,000 slum dwellers would be displaced. But what we found, and what folks who work in the slums of Nairobi recognize, is that it's not just about, the river acts as a point of not just where people live, and we documented in sort of doing this mapping some of our ability to count who was going to be displaced, but also the livelihoods that would be displaced, things like urban agriculture and other things. This image down here is an image of a guy brewing something called changa, which is an illegal brew that's brewed in Mathare along one of these tributaries. When this plan came out, the sort of government and UNEP didn't really recognize or engage with these guys who do this illegal brewing. They sort of ignored them like they ignore a lot of other slum issues. These guys obviously act as a major economic generator in this place. They also are tied into the gangs, and Mungiki, the major gang that often controls what's going on in some of these slums. So the idea is that if you're going to intervene in a place, you need to talk to people, you need to understand what's going on, you need to think about how an environmental and environmental health intervention is really tied into livelihoods. And that's one of the things we've been trying to do in Mathare. These are just some images that our students actually created in partnership with the University of Nairobi School of Planning and Architecture. Our students from Berkeley were really working with folks to try to, in our community meetings and planning process, to envision a new future and actually to cost out and look at the construction materials about how do we do this around infrastructure, creating new marketplaces, new drainage systems, things like that. So we're really working to try to think about the integration of, say, infrastructure and how it will impact livelihoods. Housing obviously is a major issue. One of the most difficult negotiations that we're involved in and our partners is in many informal settlements in Nairobi, there are a small number of structure owners. These are sort of landlords that rent out to tenants. And they have a disproportionate sort of control over what's happening and housing. So these are just some images of some of the things of where we start with sort of informal housing, often on steep slopes. Mathare is a former quarry and slopes down steeply into these rivers. We sort of generate all kinds of architectural drawings and designs of what could be possible and really translate this into incremental slum upgrading. This is in-place upgrading that's done by residents and really is important, again, getting back to those micro-saving schemes which help partially finance that and pay for the building materials and generate employment opportunities in these places. And this is just an image of another settlement adjacent to Mathare and not too far from Korogocho called Huruma, where our partners have been successful in doing this upgrading. This is really acting as our model in Mathare. And really, these are some images of the difficult negotiations and community meetings that we've held to try to build consensus and build collaboration with residents over the type of housing, who gets what. Living on the ground floor could be more advantageous for economic selling goods out of your front door, for example, than living on a second or third story, and how does that work, and what are the benefits and drawbacks from different design configurations. So these are just some of the things that we're doing in our sort of integrated slum upgrading process. I'm just going to close with some thoughts from our experience of our partnership with Pamoja and other folks, and where we're trying to move this forward, including bringing in more public health work to the sort of urban planning and architecture work that we're doing. And really, what we've tried to do is really consider the cumulative impacts, as people have talked about, not just one disease at a time, thinking about the historical conditions, lots of cultural, historical. Nairobi's a colonial city. It doesn't look the way it looks because by accident. There are some specific design and sort of segmentation of the way things are laid out that were conscious decisions. So how do you understand that, but also then try to intervene? We're working with the Nairobi City Council, UN agencies, Ministry of Lands, World Bank now is trying to generate a new slum upgrading program that's trying to build on, but is a little bit different than the existing Kenya slum upgrading program that built some of that affordable public housing that Dr. Zulu was talking about in Kibera, which, by the way, the government built, not using this kind of model here as a slum upgrading strategy. They finished this housing, what was it, last year, I think, and they said, okay, guys, you can move back into these new apartments with water and a toilet. And many people said, I don't want to live there. And one of the issues was there was no planning with community residents and with local organizations about the design of the housing, of the drawbacks of living on the third floor and losing your ground floor structure, even though it was informal. So what's happening now is many folks in Kibera are taking that apartment and renting it out and staying in their informal structure. So really community-driven upgrading, what we're talking about, can work. It takes a while, it takes investment, it takes partnership, but it starts with microcredit saving schemes and builds community power, economic and political power. It includes planning, but it also includes major investment by government and external financiers to really take this to scale. We can't do this, if you're going to do infrastructure, you can't do it settlement by settlement. You've got to think about citywide infrastructure upgrading, and that's where in countries like Brazil and Thailand, they've done that. And one of the things we're really trying to focus on is to improve the health accountability and monitoring. And that's part of our partnership with Lee and others, is to track outcomes and adjust interventions informed by health determinants, behaviors, and outcomes as we go, and to really bring health into this conversation more than it's been in the past. So I'll stop there.
Okay, so I was asked not to use any slides, and I actually listened. So you're just going to have to listen to me. Fortunately, Jason and Lee both showed a lot of pictures of what you typically see in slums, which is a lot of really, really, really dirty water and garbage everywhere. So I want to start off with a slight historical perspective on diarrheal diseases. So it's been suggested, there's not a lot of hard evidence, but that diarrheal diseases actually evolved when humans started living in settlements. So as we transitioned from hunters and gatherers to living in settlements and became agriculture-based societies, that's when diarrheal diseases evolved, because we started living in close proximity to each other, in close proximity to our feces, and in close proximity to animals and their feces. And so all of this created this wonderful breeding ground for evolution of diseases that infect our gastrointestinal tract. Historically, we do have good evidence that most of the large outbreaks of diarrheal diseases have occurred in slums. So for example, in New York City, there were 3 large cholera epidemics in the mid-1800s, and the folks that got sick, by and large, were not the rich and wealthy folks. It was the folks living in the slums, because the rich folks could buy safe water. They had sometimes indoor plumbing, and they just took off and went out to the countryside where there wasn't as much contaminated environment around them. And so it was the folks that were stuck in the slums, that were basically living in piles of excreta, that were the ones that got sick. And these epidemics were huge, killing sometimes 5 or even 10% of a city's population in the US. Okay, so now we don't think of diarrheal diseases as being a problem in the United States. And they're predominantly not a problem. And we didn't get here by providing better vaccines and by better drugs that treat diarrhea. We got where we are now by providing better infrastructure. So there are some cases where vaccines and better therapeutic drugs can play an important role, but that's not how we got where we are now. So we got here by providing better piped drinking water supplies, where we disinfect our drinking water, and we have indoor plumbing where we flush all of our wastes away with a lot of water. We contaminate a lot of water in the process, but we treat that water and disinfect it before we discharge it back into the environment. So that's the status in the United States, but you've gleaned from some of the prior presentations that that's not the case in much of the rest of the world. So there are still an estimated 2 million deaths every year that are caused by diarrheal diseases. So that's like 5,000 deaths a day. It's mostly young children. And and why is that? As you can tell from the story of the United States, we know that improvements in infrastructure can prevent much of these diarrheal diseases. So from intervention studies, there are pretty powerful estimates suggesting that, for example, we could prevent 4% of all deaths in the world and about 6% of all morbidity measured as DALYs by providing adequate water and sanitation infrastructure. So the stats on who lacks basic water and sanitation infrastructure kind of speak for themselves. There are about 2.5 billion people that still don't have adequate sanitation, and about 1 billion people that don't have adequate safe water. Most of those people actually live in rural areas, and so in most of the investments that are going on to meet Millennium Development Goals in water and sanitation are focused on rural areas. But the statistics really overlook most of the problems that exist in our cities. So just like Lee Riley was pointing out, we don't have good data about what's going on in our slums. And so a lot of the people in urban areas are counted as having access to water and sanitation, but it's not actually adequate. So most water supplies in urban areas are contaminated. And contamination of water is not actually included in these global statistics. And water's a lot more likely to be contaminated in urban areas and in slums than it is in rural areas. So I want to now turn to why slums are particularly unique in terms of well, we're clearly over time. Can I keep talking over this? Can you hear me? Okay, we're going to get the loud bell now, probably. So we have solutions for providing safe water and sanitation. We have infrastructure. I mean, the US and Europe are examples of the fact that we have solutions. These are long, right? Okay. So what is it that makes the solutions that we currently have, can we just take those and transfer them to slums? So there's a whole bunch of different things that we need to think about when trying to answer that question. So one of them is that, of course, a lot of folks living in slums have insecure land tenure. So who wants to invest in long-term infrastructure when it's not clear that who owns the land or how long people are going to be able to live in their particular spot? So individuals don't want to invest in permanent infrastructure, and governments don't want to invest in it. So what do people do? So in all these slum areas, they're forced to rely on solutions that sometimes sound pretty ludicrous to us, but there's a famous thing called a flying toilet in most slums where you poop in a bag and then chuck it. And there's a really interesting solution that's just been unveiled to try to solve this, or as an interim solution towards this flying toilet problem, which is to provide a better bag to defecate in. So there's a new bag called the pee-poo bag that is supposed to provide some disinfection of the material, and the bag itself is compostable. So at least when you chuck it, it will biodegrade, and it'll be a little bit less likely to carry diseases. I mean, it's pretty sad, right, that that's what we're thinking about in terms of innovative solutions. So there's open defecation areas in most neighborhoods where there are acceptable areas that you go to defecate. And of course, for women, this is a bigger problem because it's less acceptable to be seen while you're doing this. So women end up going before the sun comes up or after the sun goes down. And so then that brings up personal safety issues. There's public toilets, which are in most cases just completely abysmal, really dirty or really unaffordable or really inconvenient. And then in terms of water, there are a lot of illegal taps that go into municipal water supplies, or there's a lot of water vending. So people buy very small amounts of water just to meet their basic drinking needs. So there are incremental solutions that can be used to address these really informal settlements when land tenure is a really significant problem. And for the sake of time, I'm not going to go into a lot of examples, but I just want you to know that is one really important area to work. But I also wanted to think about what are the longer-term solutions, because ideally, even folks that are living in these informal settlements, we want to transition them into formal settlements, but we don't have really a better toolbox of solutions even in that case. So first of all, we have to just think about this in terms of cost. So the typical package of services that we would use in the US or in Europe costs a lot. It involves flush toilets, and we use enormous amounts of water in order to flush our waste and maintain hygiene. So you've got to get the water, you've got to treat it, you've got to pipe it to people's houses, and then you've got to take all of the wastewater away and then treat it and get rid of it. So, and sewer systems actually are about at least half the cost of the total cost on the sanitation side. Sewers are extremely expensive. So if the World Bank estimates that a reasonable investment rate in water and sanitation services is about 1.5% of GNP. So if we prescribed typical US package of services for a poor country, in most cases it would take them hundreds, if not thousands of years to invest adequately to build up all this infrastructure. So it's just completely absurd. It's not a sustainable solution. So that means we've got to think about low-cost solutions. So low-cost solutions, the standard services that are out there are a pit latrine, and maybe, well, in an urban area, it's still basically municipal water supply. But instead of getting it piped into your house, you have a tap in your yard, or you have one tap per block, and so you go and fill up containers and bring it back to your house. One of the unique challenges of working in slums is that folks in slums know what kind of services the people in the rich areas have, because they work in them, or they, they go into the center of the city and visit government buildings or businesses where they have US-style infrastructure. So that creates a different desire on their behalf than you might find in rural households, where a pit latrine and a local well might be considered adequate, by the households and something that they're willing to invest in. So in slum areas, most surveys that have been done, so in the few cases where people are actually asked what they want, you find that they usually want flush toilets and in-home water. So this creates, a huge dilemma between what's affordable and what is desirable by these households. And I also want to point out that sometimes flush toilets are provided in slum environments, just like they're provided in high-income households. And unless you also deal with what comes out of those flush toilets, you usually make the situation worse rather than solving it. So sanitation is really a community problem. You may be successful at getting fecal waste out of the household, but if they're just deposited in the street right outside, or in an uncovered drainage sewer, then you're actually increasing your community's exposure to that waste. So what actually goes on in terms of investments in water and sanitation is also important to know. Almost all of the investments that are made globally are in US-style infrastructure and in providing that infrastructure for dense urban centers and wealthier neighborhoods. So in a typical World Bank finance project, about 95% of the funding will go towards that US-style infrastructure, and then they set 5% aside for the poor folks. And so you've got much less money to work with, and that also limits your options. I don't want to underemphasize that there are some really innovative solutions that have come out of projects that are funded by this smaller 5%. So Brazil is particularly has particularly contributed to innovations like condominial sewers. So lower cost sewers that are much faster to install and are buried much at shallower depths. There's a whole bunch of engineering details I won't go into, but that cost half as much or even less of a typical US style sewer. All right, trying to decide what to do with my few remaining minutes. Okay, a couple of other things I want to point out from some of our field work. So now I want to think about drinking water. And drinking water, really the best way to supply water is through a piped supply that's managed by a centralized utility. So imagine that you are able to do this for your city. The typical practice in developing country cities is that the water is not supplied continuously. It's supplied intermittently, so maybe for a few hours a day, a few days a week. When this happens, your pipes are sitting there without water in them or with low pressure, and this allows contamination to go into the pipes. So all of this effort is invested in treating the water and piping it out to the residents, but in the process, in the way that it's operated, it actually gets recontaminated. So if you're a rich household, you can afford to buy a $150 or $300 nice little treatment unit that you install in your kitchen, and you can treat your drinking water yourself. If you're a poor household, you have very few options that are actually effective and work to do this. Furthermore, if your tap is in your yard or you're sharing it with your whole block, you've got to go and collect the water and you come back and store it in your house. And when water is being stored, it's also subject to recontamination. In fact, there's really no case that anyone's ever looked at where water is stored safely and doesn't become recontaminated. So you can, there is such thing as a safe storage vessel that you can't stick your hands in, but the uptake of these has not been very great. So even in the case where we are providing sort of US-style drinking water supply, the poor households may not benefit from it. It's considered completely acceptable to provide just a yard tap or a neighborhood tap. And the piping that you need to take the water from there into your house, that's usually a cost that's borne by the household. And poor households can't invest in that. No one's ever proposed, well, maybe we should use subsidies to help poor households get the water into the kitchen so that they can actually, these households can actually reap the benefits of a safe water supply, if there is a safe water supply. Okay, so a few last points on why, kind of tie this back to things we've already heard today and why we need more comprehensive solutions when thinking about slum health. Clearly, solving water and sanitation problems is often an infrastructure issue. In some cases, there's no room for a toilet in a house, but in the process of slum upgrading, you can design the improved housing to have room for a toilet. In paving streets, you can design for there to be covered drainages so that you're not exposing the residents to open sewers. There's also a lot of health interaction. So it's kind of, the interaction between diarrhea and malnutrition, for example, is kind of a chicken and egg thing. It's not even really clear which one starts first because they both exacerbate each other. A more specific example is, a lot of attention is being paid to addressing HIV and AIDS, both prevention and also treatment. Waterborne diseases are one of the most common causes of death for AIDS patients. So cryptosporidium in particular is not lethal to someone with an immunocompetent immune system, but for an AIDS patient, it's actually deadly. So even in the US, if you are an AIDS patient, you're recommended to not drink tap water because there's a small risk. There might be cryptosporidium in it. I also think that slums might be perfect breeding grounds for the development of antibiotic-resistant strains of organisms. So for the few, so there's many organisms that cause diarrheal diseases. So you haven't heard me even mention very many specific organisms because there's so many viruses, bacteria, protozoa, and helminth parasites that cause diarrhea. In a few cases, we actually have therapeutic drugs that can decrease the severity of an infection. And so we want to be out there monitoring to make sure that we know when antibiotic resistance is occurring. And the final thing I want to just emphasize is the importance on prevention versus treatment. So it's a very common mentality in delivery of health services to just think about, well, how can we get better treatment of cases that occur? So rotavirus, for example. Rotavirus in the US is rarely deadly for a small infant, but in developing countries, it's often deadly because there isn't adequate treatment provided. So treatment is a really important part of the package of services we need to deliver in slums, but it's not an important long-term solution. So we have to look at the root causes of these diseases. So I've obviously focused on diarrhea because that's what you largely can prevent by improvements in water and sanitation infrastructure, but you already heard Lee talking about leptospirosis, which is sort of is also spread through the similar kind of conditions that exist when you have poor water and sanitation. So I will stop there, and thank you for your attention.
Very nice, Sarah. That was really nice. Well, yeah, we are actually, because I'm not going to have that much time at the end necessarily, so what we'd like to do is invite you up. The reason is because this is being broadcast, and so therefore we do need you, otherwise we could do it more formally. But we would like you to come up, and then I'm going to moderate questions from the floor for 5 or 10 minutes, and we'll go into our second panel. Good? Okay, and please repeat, these are on, so please repeat the question so that it can be recorded. And with that, are there any questions and comments from the floor? Okay.
Question for Coburn. Glad you brought up the microfinancing aspect that's going on. It's something I'm very excited about, seeing how it's been successful in rural areas. Can you actually give a little bit more examples of some of the successes specifically in certain places of how it's been successful?
Okay. The question was, can people hear me? The question was about microfinance in informal settlements and what some examples, or how does it work? Yeah, as you may know, this is not unique to Kenya. The organization that we work with has a particular model of microfinance that starts with very small micro saving schemes at the even sort of areas within an informal settlement that could be anywhere from 5 to 10,000 people that make up a 500,000 person slum. So those small saving schemes have a number of different functions. They save about $1 a day. They go door to door. They also have things like they do small loans. They have their own accounting. They also get involved in the planning work that I talked about in terms of this household surveying, mapping. So they serve a number of functions. Those all of the saving schemes that are organized by this organization, Pamoja Trust and Muungano, their sister organization, are part of a national network. So within each slum, you will then have a group of these saving schemes. And those saving schemes in Mathare, the one that slum I was talking about, would then have a connection to the saving schemes in Kibera and the rest across the city of Nairobi. They would form a network, a metropolitan network of micro savings. That network that would then be networked with other cities around the region and around the whole country. And then they have a national sort of council. And part of that national council has been, they've created a separate organization which has enabled them, sort of spin-off NGO that enables them to then go to international donors and lenders to get loans and money that then can go down to these smaller saving schemes at the community level. So it's a very complex structure. It's networked. They do a lot of things besides just saving money and giving out loans. And one of the things that we're working on, and I have a student doing some research on now, is many of you may know that Kenya has something called the M-Pesa program, which is where you can do banking and exchange cash literally in your SIM card on your cell phone. So the question, and a lot of organizations are saying, well, this is the future of micro savings and getting the unbanked banked and getting them into the formal banking sector. It creates real potential tension with these NGOs that have built this complex infrastructure of micro savings. So one of the things we're looking at is both the tensions and opportunities of things like M-Pesa. There's also a small bank growing called Equity Bank that takes in the poorest of the poor into the formal banking sector. So it's a very complex system in Kenya. It's emerging, it's changing. It's similar kinds of examples around the world around microfinance. But the important point is that it does more than just economic savings, builds political power and local organization.
Can I just ask, since we're talking about interventions, one thing I just wanted to follow up, Lee, you mentioned that the data that you produced around the leptospirosis surveillance in Balderima and Dhaval was taken up as by the Brazilian government and they asked for more surveillance, but I thought that they'd actually done some infrastructure improvement as well to go along with that as an intervention powered by or generated in response to the evidence.
Right. Did everybody hear the question? So I guess the question is that did the government Brazilian government do something about the findings that we made from our study on leptospirosis in Pau de Lima, which is the favela that we worked in after we published our findings, and the answer is yes. because of the report that we provided, they came in, it wasn't the national government, it was the local government, the city government, came in and put in piped water systems and then cleaned up the garbage and then tried to reduce the rat population. But the problem is sustaining these types of interventions. After about 2 years, sort of the situation went back to the way it was because they were not maintaining the piped water and the rat control. And so that is an issue. But they did make an attempt to intervene, and that did have an impact, not just on leptospirosis, but in reducing, for instance, diarrheal disease incidence, because the same intervention applies to many other diseases that occur in these situations. So.
So Professor Riley talked a little bit about how you have to present governments with specific data so that they can use it in kind of a tangible sense. And then Professor Coburn talked about addressing kind of like the historical and social context in which these like slum settlements kind of have been created. And so it's kind of like how do you reconcile that kind of disease-specific data with the overall context in which people live their lives to kind of lead to sustainable interventions, kind of scenario what you just said. It's useful for a period, but then kind of the issue that caused the substitute in the first place leads to the problem kind of happening. How do you kind of reconcile both of those things?
So I guess I'll answer first. Yes. So this is an issue. So the question is, how do you reconcile trying to provide detailed data, meaning doing research, versus sort of trying to understand the social context in which favelas, the slums, get established? And this is kind of a debate that Jason and I actually, have discussed this as an academic. We're both in academia, and we have different approaches to sort of addressing the problems of slums. I do research. My group does research and try to generate data, and Jason tries to attack this from understanding the sort of the social context, and then try to then use that to upgrade the slums. And I don't have a real answer, which is the way to do it. I think we have to do everything. I think Dr. Zulu mentioned this, that we have to do everything we can to come up with new interventions that will have an impact in these communities.
Yeah, I think that's exactly right. I mean, it's not either or, it's both and. One of the things that we do with our partner, Pamoja Trust, and these saving schemes is that they do household enumerations. Sometimes every 6 months they go door to door and document all the kinds of demographic infrastructure. They ask some health questions, but one of the things we're doing is building in more health questions. And so the regular collection of data, again, the counting and then being able to map this and provide sort of longitudinal data provides an incredible set of information, but also power for local organizations. And in fact, Pamoja Trust, the NGO that we work with, has been so successful doing this across Kenya that they are now being contracted by the World Bank to provide the data for their National Slum Upgrade Program.
Thinking about target populations of slum, I wonder, I'd like to hear some comment that we should encompass situations like refugee camps on one hand, and on the other hand, the ethnic ghettos in major cities in more developed countries. How these situations are to be included or not included within this field of slum health and urban health.
You're asking everybody, I guess?
Yeah, I mean, I just have a quick comment on that. If you look at this, this may be, driving your comment. The state of the UN's State of the World Cities latest report. They document the differences across continents. But one of the things that I thought was really important and telling in that report is that there was a section that highlighted vast inequalities in the United States in urban areas. And they blame it, or they cite racial residential segregation as a major driver of health and social disparities in the United States that have not been addressed. And that to ignore that and to ignore, how do you address that, how do you address those solutions, is to ignore a big piece of the global puzzle of solving this.
Maybe I'll just add on to that by saying that it's all a continuum. I mean, maybe we haven't emphasized that enough, but there's no specific typology of a slum, and so poor income neighborhoods in industrialized countries have a lot in common with those in developing countries, and then within developing countries, there's this huge, wide spectrum of conditions that exist. So I don't think that any of us is saying we need to figure out the slum. We need to understand the conditions in each specific area where we're working.
Here's a good example of this is what happened in Haiti, right? As I pointed out, slums have always been in Port-au-Prince, and after the earthquake, the same conditions just got bigger. Yet, so the solutions will probably be the same. Just that now they have to deal with it. So the slum populations suddenly came to be called refugee populations, but the conditions are the same, and so I think the solutions probably are going to be the same.
But on that note, I think that we need to do a much better job at using emergency situations, which bring in a lot of both money and human resources to address the challenges. We could do a much better job at planning recovery efforts that have long-term impacts than just short-term impacts.
So you've all discussed your work in terms of research, policy, or market-based strategies in improving health conditions in the slums. So my question is if you've tried to implement any behavioral change interventions, and as a mechanism, how effective do you think it is to improve health? Let's go ahead.
Well, for us, I mean, thinking about behaviors for our work is intimately linked to place-based conditions. So, hygiene behaviors or other kinds of health behaviors, as I think Dr. Zulu was pointing out, are driven in large part and shaped in large part by economic opportunities, opportunities to move around, to resettle if you're under threat of displacement. So to not decouple behavioral change from larger community and place-based change is the focus of our work. So, I mean, that's avoiding an answer to your question. Yeah. The shorter answer would have been very little work around individual behavioral change, mostly around community behavioral change, but putting it in a larger context.
I'll just add on that clearly the inability to change behaviors has limited the effectiveness of every household targeted water and sanitation intervention that's out there. And but like someone like myself, I'm not trained as a behavioral scientist, so I can't do the research myself, but the way I see integrating this into my research program in the long term is by collaborating with folks that do research on behavior change. So for example, Professor Isha Ray, who's in the Energy and Resources group, I collaborate with very closely, and she's hoping to increase the part of her research that addresses behavior change in the specific context of water and sanitation.
Just quickly comment. Behavior is something that's highly dependent on the environment of an individual, and without really trying to do something about the environment, I think it's going to be very, very difficult to change people's behavior. For instance, with leptospirosis, we already know what you need to do. Just don't walk in contaminated water. But how do you tell people when everything's flooded, you have no place to go, the only way to get to places is by walking through the water? How do you do that? You can't change the behavior until you change the environment. Okay?
We're actually going to take one more question on this panel, but the next is actually a conversation with the audience, so you'll have a moment. I just had already said you guys want to.
Yeah, I was just thinking it was Dr. Zulu who presented that the greatest concern among people living in slums is the lack of jobs. And it seems like at the same time there's an opportunity for meaningful jobs in the slums, like environmental workers, people to help clean up, community health workers, school teachers, etc. Are you familiar with any projects, maybe it's a private-public type partnership,
that has been successful in creating jobs, and that's also sustainable, which I think is the hardest part.
Yes, there are a number of, first of all, it's, I think, incorrect to say that slums, at least in the ones where we work in Nairobi, don't have jobs, people don't have access to some employment. I mean, there's lots of controversy over this issue that, you know, slum dwellers aren't poor or whatever. There's the very poor, the poor, and the somewhat poor spectrum, even in Nairobi slums. There's a lot of informal work going on that sometimes gets captured, sometimes doesn't get captured. One of the things we've tried to do around upgrading is use it as an economic engine. And in fact, UN Habitat did an infrastructure investment in Kibera. They paved roads and did some other things that were somewhat controversial, but they employed local people in doing this. Right now, in a informal settlement called Kosovo in Mathare, where we work, part of our work to help plan for new water pipe construction, including water kiosks and individual home connections. All that construction is being done by youth in the slum. The housing upgrade, we actually work to build the cement blocks in the, you know, it's incremental in-place upgrading. Residents build the blocks that are then used with steel reinforced rebar to build their house. So the idea is that this work generates jobs, but there is a very complex informal economy already in place that you don't want to ignore or disrupt.
Okay, thank you very much. There's a live question. What are you saying? Okay, I'm continuing. I just want to thank our panelists for their talks and for their comments in response to the questions, and thank the audience so far. Although what we're going to do is going to kind of continue this with a different panel. People who can address this from even more perspectives. So thank you.